So I was given the task of talking about something really boring, but I'm going to try to make it as relevant as possible and prove to you why we should start caring about documentation now. All right. So I'm only going to focus on two things overall, like the two most important things. And one of those is litigation, because most ER docs, actually all ER docs, get sued in their career at least once. And the other thing is reimbursement, right? You work your butts off in residency. And at this point, you want to start making money and you need to document effectively to put money in your pocket. Because if you don't, you're going to have like a STEMI case and you're going to go home with like $10 from that case because you didn't document because there was other stuff going on or whatever it might be. So yeah. So let's start with the case. I want to preface this by saying hindsight is always 20/20, right? This case that I'm going to talk about could happen to any of us. We don't know what the ED was like that day. I know it could be really busy sometimes. And when you notice that your work is getting sloppy, you have to tell yourself that you need to kind of draw the line, take a step back, and either pick up a few less patients or go back to the bedside to get a better idea of what's going on with that patient so that you don't continue sloppy work, because more sloppy work equals poor documentation equals more likely to get sued. So it's all just kind of like a downward spiral that you just never want to be a part of. And I feel like if we don't start practicing this now, when you become an attending on day one, it's not just going to come to you, right? So it's about building those skills right now. All right. So there's a diabetic adult female patient that presents to the ED with leg weakness and leg heaviness. There are no gait, reflexes, or strength documented except a nursing note that says up to bathroom, steady gait. WBC count is 15.7. Her BGM is a little in the 200s. She has a history of diabetes. And she was discharged. She was diagnosed with a questionable pneumonia and was sent home on azithromycin. So now her second ED visit, 3 days later, she goes to a different emergency department. She has right-sided back pain radiating to her abdomen. And on the exam, it says patient moving all extremities, no gross neurological deficit. That's fine, right? If that's the truth, if that's accurate, that's fine. The glucose is now 377 and her white count is 10. The dimer was normal. They also did a renal ultrasound, which was normal. She was given Dilaudid for pain and switched to Bactrim, which to me is just like really poor medicine. I don't really understand, but to each their own. And then the patient was discharged in the note saying, quote unquote, ambulatory to see the primary care physician in 3 days for a possible outpatient MRI. Cool. Another 3 days go by and this patient comes to the emergency department again. And on the exam, it says no Cotta-Equina syndrome. They used he instead of she for this patient. They said the patient had hypernatremia instead of hyperglycemia, which sometimes can happen when you're using your Dragon or if you have a macro that you didn't fix, like a dot phrase that you didn't fix your text on. There was no gait that was recorded, and the patient again is discharged home. But then the patient falls upon arriving home. So 911 is called and EMS brings the patient back to the emergency department, the same one. The chief complaint is mid-back pain now. And the review systems is contradictory. It says negative for back pain, and then there's a plus next to back pain afterwards. No focal weakness on the exam. There was no temperature recorded. And on the exam, this is what it says. It says the patient has left back tenderness instead of right. Decreased sensation to the umbilicus, inability to walk, and rectal tone is present. So now they ordered more labs. Her white count is 1700. Her CRP and ESR are elevated. And a lumbar-only MRI was ordered to rule out an epidural abscess. What are your thoughts on all of this so far? No thoughts? Any thoughts? Yeah, she keeps representing. Something's not right. The math is not mathing. And the documentation, as you can see in every single visit, there's some discrepancies there. And the discrepancies are not okay, because that's what, at the end of the day, gets us in trouble. This doc may have been really, really busy. It might have been a doc that's never seen her before and knows nothing about her or didn't chart check or whatever it might be. But at the end of the day, when you have to go to court, that stuff is indefensible because it's not in your documentation and it's not accurate to what actually the patient presented with. And this happens to me all the time. Like I've written right instead of left before for like a hand lack, or like he instead of shit. Like those things happen and that's okay, but we have to make sure that we correct ourselves when we do, because if things progress in the wrong direction, it's on us. So she's transferred 8 hours later to a tertiary center and she's admitted with sudden inability to ambulate and loss of leg sensation. The focus remains on pneumonia as a cause of her elevated CRP and ESR. And then referring hospital wrote that there's a concern for epidural abscess and it's dismissed because her MRI was negative. So the next day, the neurologist records that the presentation of this patient is suggestive of embellishment and malingering or a functional disorder, and they order an EMG, which is non-diagnostic. So the patient had a renal ultrasound, they had a lumbar MRI to rule out an epidural abscess, and then they had an EMG, which was negative. And now finally we get to the point where the MRI of the full spine is ordered, which is the appropriate workup for ruling out an epidural abscess. You never order one part of the spine. It's got to be the entire thing because you don't know what part of it is causing compression. You don't know where it starts, where it ends. So if you're committing yourself to that epidural abscess diagnosis and you're ruling it out, it's an MRI of the entire spine always. So if I ordered an MRI of the L spine on this patient that I was suspecting an epidural abscess, when I go home that night, I would not be sleeping because I know I didn't do the appropriate workup. So this is the MRI. What are your thoughts on this? Anything jumping out to you? I know there's arrows everywhere, so what do we think this is? There's a lot of foreshadowing. So, yeah, anyone? No.
Like a collection in the posterior spinal column.
Yep. Exactly. Exactly. Yep. So this is a thoracic spinal epidural abscess as the final diagnosis on this patient. The patient becomes paraplegic and a lawsuit is filed. So the plaintiff, the patient, says, you should have made the diagnosis on the first visit. I had leg weakness. There was no neuro exam. I had a high white count. I'm a diabetic, and you assumed that I had a pneumonia. What were you thinking? I had 2 other ED visits at another hospital. Your computer-generated records make you look ridiculous and can't be believed. My numbness is indicated at thoracic level, but you only did a lumbar MRI. You thought I was faking it, and now I'm paralyzed because of your incompetence. And the defense says, well, we think we did the best that we could given the circumstances. Maybe we should settle this. So the result was a multi-party pre-trial settlement of millions of dollars. So what I want to say, my take-home point from this is that the EHR, right, your epic can be your best friend or can be your worst enemy, right? In this case, the entry errors made the doctor look really silly. You lose your street cred, right? Like no one cares about what you have to say when they look at this legal document that you typed up that looks like trash, essentially, because there's so many discrepancies. So is what you wrote accurate and precise in terms of the time, the events that took place? Does it support that you actually saw the patient or only that you clicked a few buttons and boxes and maybe some of the wrong ones accidentally? So any pearls from this, any takeaways that you guys got from this case? And I'll go through mine.
I guess it's just, it's obvious, but like, you don't actually know to what degree they did the right thing or they screwed up because they didn't really document anything.
Yeah, exactly. And it's not always our job to get down to the bottom of the problem, right? It's our job to rule out life-threatening illnesses, and patients might not present with the findings of an epidural abscess, but it is a dynamic process. So you want to document exactly what you saw that first time, and the second time maybe there is or there isn't progression of that, and that's what's going to save you. So exactly, that's one thing. And some of the lessons I learned, if your diagnosis is pneumonia, make sure your documentation supports it. Avoid any preconceived notions. Avoid writing things like embellishment or malingering in one of your notes unless there's a previous psych diagnosis and a psych note that says this patient is a malingerer because he presented with XYZ, right? It's like when your patient comes in with like upper abdominal pain and you know that the answer is gastritis, but you don't write gastritis as your diagnosis unless there's a scope that's documented in that chart that says the patient has a history of gastritis, right? You say epigastric pain or whatever it might be. If you do a CRP or an ESR, remember those are really non-specific tests. So don't disregard the result or attribute it to like a pneumonia. That's not really right. Document a thorough neuro exam on my headache patients, back pain patients, any vasculopath patient that I'm maybe worried about a dissection or like limb ischemia. I always document like a head to toe neuro exam, and I always make sure that I do exactly what I document. Lastly, for any neuro complaint, make sure you're watching their gait before they leave and you're writing in your note at the end, the patient remains neurologically intact with a steady gait upon discharge. It takes 2 seconds, especially if you use Dragon, or you can just put in your dot phrase too for that. And then we talked about how to, working up an epidural abscess. So people say this a lot. If you didn't write it down, it didn't happen. And I think that there are some extremes of this. You don't have to write down every little thing. However, the things that are clinically relevant, you do have to, especially if there's a patient that we have like a diagnosis of, we don't have a diagnosis and we're uncertain about what they have. So just something to think about. I think about this all the time when I am reviewing my charts and I was like, I should have added this and I didn't, or I did this, but I didn't, mention it. So what are some other reasons why documentation matter? We talked about the legal purposes or the legal implications. What are some other things? Yeah, money in the pocket. Exactly. What else?
The ethical implications of documenting well, so the next provider that sees them can actually have a good understanding.
Exactly. So that's the first thing is communication, right? Rarely is an ED encounter so self-limited that nobody else knows about it. And usually we're the first people to document patients' past medical histories, their surgical history, and that stuff you can see the medicine residents copying and pasting into the chart forever until the end of time, right? So we have to make sure like the onus is on us to make sure that that stuff is accurate because it's really important. The next thing you mentioned billing. We're going to go into this because I think there's a lot of like nuances and caveats of billing, but I'm going to keep it really simple. And hopefully it'll motivate you to start practicing writing like good notes so that when you leave and you provide all this excellent care, you're actually getting reimbursed appropriately for it. And then we talked about medical legal protection. Obviously quality improvement is another one. Research is another one. Risk management, right? We talk about all this stuff in like the peer review meetings where we bring up cases and see how we can approach this from a system standpoint and make things better so the same mistakes or problems don't slip through the cracks. This is what I usually put in for like first years, which we don't really have to go through because I think you're all aware of this stuff. And again, qualities of an ED note, it has to be complete, accurate, concise, and organized. Those are the only things that I think about. So something I wanted to mention, the billing has changed for our documentation over the past like 1 to 2 years. Is everybody aware of that? Okay, so I guess what's the most important part of your note now based on the billing changes? The what? Yeah, the MDM. Everything is in the MDM. Your HPI does not matter really. However, if you don't want to get sued, your HPI does matter. So I usually put in a one-liner of like, if I have a chest pain patient, I'll say like 59-year-old male with history of XYZ presents to the ED with right-sided chest pain that started a day ago, non-radiating. I use this mnemonic and I still put in my like one-liner of that. But then afterwards, I'll copy and paste this into my MDM, the one-liner, and then I add all of the other relevant information that I'm going to talk to you about today. Next thing is review systems is out. At least the box and Epic is out. However, I think it's still really important to include your pertinent positives and negatives in your HPI. So if you're like patients presenting with PE type symptoms, you want to include your Wells criteria in that. If you don't want to put it in your HPI, that's fine, but make sure that it's in your MDM. Physical exam. Since I've been here, I've noted a lot of dot phrases and people not editing some of the dot phrases. So like a patient comes in with like excruciating back pain, but then there's no like back exam on it, or the back exam is noted to be normal. So just make sure that you're looking through your note and not having discrepancies like that. And negative pertinent information is also important. If somebody's coming in with right lower quadrant pain, there should also be like a CVA tenderness, positive or negative, included in that, right? If they're a male coming in with left lower quadrant pain, there should be a testicular exam that's added to that, right? Because that's a part of your differential. So really important, it takes 2 seconds to just add that thing, and you did examine it, right? So make sure it's on there so that you're setting yourself up for success. Return precautions, another thing. So on notes, I think it's really important to create a dot phrase for really like common complaints, like your chest pain, abdominal pain, back pain, headaches, and then your pediatric like important complaints like URIs and vomiting, right? You literally just have to put that dot phrase in at the end of your MDM or at the end of your ED course, saying that I discussed this with the mother or I discussed this with the patient and the family, and they understand. It takes 2 seconds. And then if there's something really specific or some sort of caveat about their presentation, it takes another second to just add in that one line. I also told them that, you know, if this symptom starts to present, that they need to come back immediately, right? We have our like printout discharge papers, but those aren't always the best. And so it's really important to cover yourself with this, because a lot of times the doctors get screwed over by having like not good return precautions written down, even though you verbalize it to the patient. So like your early API patients, right? So make sure you keep that in mind. If you want to see some dot phrases, if you don't have them for this, let me know and I'm happy to send you mine. I have them in English. I also have them in Spanish because I put them on the discharge instructions. I copy and paste it onto there, because if we're giving them instructions in Spanish, but then in that little box, we're writing it in English, like they're not gonna know it. So just try to keep it as consistent or easy as possible. And now we're gonna move back to the MDM. These are the things that they're looking for now. The most important thing is like social determinants of health, medical problems that the patient has that you addressed, reviewing all the data, like interpreting your EKGs, your chest x-ray, reviewing comparing it to a previous chest x-ray and mentioning that. And then risks of complications and morbidity, mortality. So this is kind of like, it's like straightforward, low, medium, and high. So this is like your basic like ankle sprain patient, right? So all of this stuff should be mentioned, that the patient doesn't have any medical problems. They're here for ankle pain. You got an x-ray or you didn't. Their risk is minimal. So these are like your easy, like level 1, 2, 3 type of patients. And then this is the criteria that they have for your low patients. So this is like a low patient would be like somebody has diabetes and high blood pressure. And they're here for like, I don't know, throat pain. It's really important again to mention that you not only reviewed your prior records, but what you actually reviewed. Like, have they had this before? Do they get recurrent tonsillitis? Like things like that. That's important to mention, because if you don't, you won't get paid. And then lastly, you have your moderate and high. These are like obviously the sickest of the sick, the patients that are usually in CCT that we see. But again, it's important to, as you see, it's like the same things mentioned over and over. Reviewing the prior records and what you saw, what tests you ordered. Did you get a history from an independent historian? Like I used to not mention all those things, but it is, because if you don't, no money in the pocket. Okay, cool. RVUs. So what are RVUs and why do we care about them? Yeah, cash. Exactly. So at Downstate or here at Kings, we don't really have this RVU pay model, but I'm going to talk to you about it today, because when you're applying for jobs, you might realize that it's more important because sometimes you make a little more money. So RVU is a relative value unit, and it basically is a measurement that's used by Medicare to detect reimbursement for a physician. Cool. So one RVU is, as of 2024, is $33.59. It's actually a drop from last year. It was like $34.70, but that's what one RVU equals. So I actually have a QR code if you want to look. Feel free to take a picture, and this shows some of the most common RVUs that you get, and we can like play around with it and do some math. And then I'll just put up this so you can, oh, it worked, cool. So if you look here at like a level 1 exam, I can scroll through it. I don't know. So basically, if you do like a level 4 ED exam, right, that is going to tell you, give you 3.56 RVUs. That's just documenting a good physical exam is what, 3.5 times $33. That's pretty great, right? Just for your exam and nothing else. So it's important to have those things, especially because you're doing it. How do I go back to the slides? Yeah, it's only 0.2 for an EKG, but they add up. Think about how many EKGs you read and review. So
Weird. Let me open back up. Fix this off for a second. Let's see. Wait, no, it's open here.
oh, it opened there.
Is it,
Okay.
is this it?
Yeah, but I want to go back to my slides.
If you look at that, then here's all that,
Yeah.
the 2.5 centimeter last region and a 2.6 centimeter last region.
It's
the
huge.
difference is hundreds of dollars. So just something to think about from the document.
Perfect.
Except the problem is it's like, so
Oh, it's not coming up.
it's okay, I'll just restart it
Okay.
and then we'll drag this back over.
Oh, magic. Okay, perfect.
And then
Okay.
where'd your notes go?
Uh-oh. There we go. Thank you.
Yeah, no problem.
Okay. And then here are some of the ones that we don't even think about that are a lot of RVUs, like a Colles fracture reduction. If you're working in the community, that's 15 RVUs, 15.6. So 15 times 33, that's a lot of money. So document that if you're doing that. A patellar dislocation reduction, so easy, right? So if you document that properly, that's 10 times $33, that's $330 just for documenting this patellar dislocation reduction, right? Some of them are a little arbitrary and random, like you don't make that much money from intubations actually, as fun as they are. But I just wanted to give you an idea so that you can see like how these RVUs are, like, you know, how they're calibrated essentially.
TMJ is one RVU,
But what is?
the TMJ.
TMJ is one
It's
RVU.
so hard.
I know. Which is why, like, no, what I'm gonna say is not nice, so I'm not gonna say it. So like, I wouldn't really, honestly, if I was in the community, I wouldn't really waste so much time doing a TMJ reduction. Because if I can't get it the first few times, I'd probably call the consultant to do it because you also have so many other patients that you have to see, right? And that's that, right? So I would give them something to relax them, and I probably wouldn't spend hours and hours trying to do that. Cool. So this is just to give you an idea of that. Also, make sure, I didn't want to talk about critical care time today because I think it's just too much to include into one talk, but there's also a huge list of critical care that you can bill for and make money for. It's like literally treating hyperkalemia, putting someone on oxygen because they're hypoxic and having a COPD exacerbation. Someone who's hypotensive that you're giving more than like 2 liters of fluids to. Anybody that you're transfusing blood into. Those are all things that you can bill for critical care time, and you can see how many RVUs that is. The first, I think the first 30 minutes is 6.3 RVUs, right? So if you're practicing good medicine, you want to be reimbursed for that, and I think it's important for us to know that this exists. There's a lot more different pay models than this, but I just wanted to keep it simple. So at King's, it's salary based. You might go somewhere else that's incentive based, where they give you like a salary. It might be a little low. It might be like 180 an hour, but you make, of all the RVUs that you make, you get to keep 80% of the money from all of the RVUs you make, and 20% is ours. So that's another possibility. You might have some CMG groups do like, again, like 200 an hour, but if you meet our RVU threshold, which is like you have to get 50 RVUs per month, if you go beyond the 50, every cent that you make after that is all yours to keep. It's easy to make 50 RVUs in a month, right? So think about how you practice, right? Are you the kind of person that, I feel like coming from King's, you have really, really good experience over 4 years where you can do so much at once and not let things slip through the cracks. If you're that person where you want to go to an incentive-based person because you know that you're going to work really hard, you're going to do a good job and make more money, then maybe that's a place for you. If that stresses you out, maybe a salary-based place is more for you. And then the other thing is there's, differentials based on if you want to just work nights, if you want to do weekends. So just some things to consider. Another thing that's boring but important, why do we care about ICD-10 codes? Like, who cares? Insurance companies, exactly. That's the only reason really for an ICD-10 code, but it's really important because the diagnoses that we're putting in have to be billable, right? Sometimes we put in like random diagnoses that aren't actually ICD-10 codes. I think Epic is good about ruling some of them out, but you might not always be at a place that has Epic. Where I did residency, I didn't. Where I did my fellowship, I didn't have Epic. So a lot of times I actually had to look up ICD-10 codes. For example, when you get like a pedestrian struck patient, like a pedestrian hit by a car, it's impossible to find because it'll say like pedestrian hit by like large tumbleweed, pedestrian hit by gravel truck that dumped on them while they were crossing the street and making a right. But you can't find the pedestrian hit by a car. It's like really frustrating. So what I do when I can't find the appropriate ICD-10 code, I literally Google it. ICD-10 code for this. And it comes up immediately and you can literally, you get all the important ones, right? Like skateboard, roller skates, like those shouldn't be at the top, but they are for some reason. So there's your ICD-10 code it's V03.9. So I just copy and paste it into that bar where it asks for the diagnosis and then you're done. The more times you do this, they'll actually just like end up staying in your mind, like the chest pain, the acute unspecified chest pain is like RO 7.9 or something. You'll when you see it now, you'll remember it. And the last thing, again, right, we put like back pain all the time as our diagnosis. Back pain is not actually an ICD-10 code. It's actually one of these, right? You have to specify and say it's low back pain or it's dorsalgia unspecified, right? So it's really important to keep this in mind because insurance companies aren't paying for your patient's visits when we're putting in the wrong diagnoses. Our patients a lot of them don't have a lot of money. And so it's really unfortunate when the insurance company doesn't cover it when they should. So it's a part of our job to help take that burden off of our patients as well. So that's just some of the things I wanted to mention. So as you can see, documentation can make a really sizable impact on us, on our patients, the rest of the care that they receive throughout the healthcare system. So yeah,